Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Hello, I'm Antonio Passaro. I'm a senior staff physician at the European Institute of Oncology in Milan, Italy, and welcome to this program titled Illuminating the Path, New Insight in EGFR-Mutant Advanced Non-Small Cell Lung Cancer. Join me today is Enriqueta Felipe, who is a professor of medicine at the University of Barcelona in Spain. Welcome, Enriqueta.
Thank you, Antonio. Happy to be here today.
Today, we'll be covering various small topics in EGFR-mutated advanced metastatic non-small cell lung cancer. This is a quick fire program that will have a maximum 90 seconds to answer each question. As there are many questions, let's cover to start with this program. So first question for you, Enriqueta. What are the currently available therapies in the first line for patients with the EGFR-mutant non-small cell lung cancer?
Thank you for the question, Antonio. So, a number of changes in this scenario. So, we had for years, third generation EGFR TKI as a standard of care. Mainly, we use osimertinib, and this is reflected in the ESMO guidelines. But we have also a number now of combinations that may improve results. So, we have osimertinib, but also the combination of amivantamab plus lazertinib of third generation EGFR TKI plus amivantamab, that is a monoclonal antibody targeting EGFR and MET. And also we have the potential treatment with chemotherapy plus osimertinib. I think although we have treated our patients with third generation EGFR TKI, the field is moving to combinations, and there is an increasing number of patients that are now being treated with combination AMI plus laser or chemotherapy plus osimertinib. So perhaps you can review the data supporting these combinations, no? And my question for you, Antonio, what data support osimertinib plus chemotherapy in the first line setting of patients with activating EGFR mutations?
So we know that the combination of OSI plus chemo was evaluated in the phase 3 trial FLAURA2. That was a very interesting trial, evaluated the first kind of combination chemo based. And we know that the results show a significant and clinically meaningful improvement of the progression-free survival with an hazard ratio of 0.62, with a difference in favor of chemo plus OSI of 25.5 months for OSI plus chemo and 16.7 months for osimertinib monotherapy. At the present time, we know that the combination improved the benefit in all the subgroups according to the progression-free survival, and also the second interim analysis for the overall survival showing a trend in favor of the combination of chemo plus osimertinib based on overall maturity of 41%, but the full analysis for the overall survival is waiting potentially to be out this year in one of the future meetings. So on the same line, Enriqueta, I have another question for you. So we know that the combination of FLAURA2 improve the efficacy in patients with a common alteration, but of course there is the issue of the potential safety reason related to the combination. So what's the evaluation for the safety profile for this kind of combination, Enriqueta?
Oh, yeah, it's important to evaluate, as you mentioned, safety, also the PFS and overall survival results. But overall, the FLAURA 2 trials show us that the incidence of grade 3 or higher adverse events goes higher with a combination of chemo plus osimertinib when compared to osimertinib alone. And the finding was driven by known chemotherapy-related adverse events. We used platinum pemetrexed. We know what are the toxicity of this combination, and we have seen also that in the FLAURA2, hematological toxic effects were reported in about 70% of the patients in the osimertinib plus chemotherapy arm, 24% of the patients in the osimertinib arm. Overall, perhaps the percentage of patients with discontinuation and osimertinib dose reduction was higher in the chemotherapy arm. So the main toxicities that we can see with a combination of osimertinib plus platinum pemetrexed included anemia, 45% of the patients, in 20% of patients grade 3. We can see also diarrhea, 43% of the patients, 11% grade 2, and nausea. So these are the toxicity mainly driven with chemotherapy. So it's important, no, Antonio, to manage the safety of the combination, no? And perhaps I would like to know your experience, how we can manage the safety of the combination of chemotherapy plus osimertinib in patients with EGFR-mutated tumors treated in first line.
So we know very well the chemotherapy, platinum pemetrexed. We know very well osimertinib, but in my opinion, the view for safety is for long-term safety in this particular setting. So I consider the data that you reviewed about the single toxicity. There is, of course, a little bit increase for the combination, not so difficult to manage in clinical setting. But at the present time, we have no a clear understanding of long-term exposure for particular for the maintenance treatment with the pemetrexed and the osimertinib. At the present time, I think that is important to assure that there are not major safety issue for this kind of combination. But waiting for the overall survival, I think that we can use this kind of combination where approved according to this kind of data, because no important issue are out for this particularly combination is in this particular setting. And we know that the Flora 2 is not only the one of the combination in this particular setting, but we know that another combination that is a chemo-free combo with amivantamab and lazertinib showed very important results in progression-free survival. And also for this kind of trial, the Mariposa trial, we have already over survival data out. So what data support this combination, Enriqueta, and of course your perspective in this field?
No, important results in the Mariposa trial. Patients with activating EGFR mutations were randomized to receive osimertinib as a control arm versus amivantamab plus lazertinib versus lazertinib that was only included for to determine that lazertinib was active in this situation. So the first endpoint of the trial was to compare amivantamab plus lazertinib versus osimertinib. Is a study that is positive for the primary endpoint, that was progression-free survival according to the blinded independent committee review. The median PFS with AMI plus laser was 23.7 months versus 16.6 months with osimertinib alone, with a hazard ratio of 0.70. But importantly, as you mentioned, at the LCC meeting this year, the final overall survival results of the trial were presented. And this is a study that is positive for overall survival. And with a median follow-up of 37.8 months, amivantamab plus lazertinib led to a statistically significant and clinically meaningful reduction in mortality compared to osimertinib, with a hazard ratio for death of 0.75. So I think it's important. You mentioned is a chemotherapy-free regimen, but again, safety is important, no, Antonio? And what is the safety of the combination of AMI plus laser in the first-line treatment of our patients?
So thank you, Enriqueta. This is a very important question. So we know that the advent of Ivantan from the beginning of the story, at the beginning, monotherapy in the Crisal in second line for exon 20 insertion patient. In the combination with the lazertinib, we know that the combination increased the rate of toxicity related to EGFR or MET inhibition that receive the dual inhibition from this kind of agent, but globally the rate of a grade 3 or more was not so high. So we have 12% for pyronychia grade 3 or rash cutaneous that was more or less the same as 17%, but globally there was no high increase, statistical increase in the grade 3 toxicity. Globally, we know that the block of toxicity that require a very important support is related to EGFR inhibition. And we know also that in this kind of trial, there was an increase in infusion related reaction that are support, and they also discuss in immunotherapy, also in other discussion, that today are in the view of the future perspective could be improved step by step with a different part of the program development of amivantamab. And in view of this, I have a question for you, Enriqueta. So, what are the advantage of subcutaneous amivantamab compare intravenous amivantamab? Consider that in the Mariposa trial, amivantamab was used the IV, but we know that we have a very interesting and impressive data for subcutaneous formulation.
Yeah, yeah. So a sub-Q formulation is will be an important one. Dr. Leis presented at ASCO and also was published in JCO. The results of Paloma 3 that patients in first line were randomized to receive subcutaneous versus IV amivantamab plus lazertinib. Sorry, in patients previously treated. So in this trial, it's important to say that the first endpoint was a PK endpoint, and this was met. So subcutaneous formulation was not inferior to IV formulation, but it was interesting that PFS was similar in the two treatment arms, but also there was an increase in overall survival for those patients treated with subcutaneous formulation. But what is important is that the infusion related reactions associated with the subcutaneous formulation was seen only in 13% of the patients versus 66% of the patients in the IV formulations. And there was some questions for the patients, and clearly the patients treated with the subcutaneous formulation mentioned that was a very convenient administration. So one of the toxicities, no, Antonio, that we need to manage with the combination of AMI plus laser is the dermatological adverse events, no? So what is your experience, your recommendation to treat or even to prevent the dermatological adverse events?
In particular, in the Mariposa 2 or Papillon, we had an experience, but the very significant improvement is a story with amivantamab is related with the study Cocoon study. The Cocoon study is a phase 2 trial that evaluated the use of amivantamab IV plus lazertinib with the standard dermatological management, started on the same usage in the Mariposa trial compared to a combination amivanta lazertinib plus an enhancement dermatologic management dedicated with product or support to reduce toxicity. We know with the standard arm, the rate of toxicity was more or less 67.5%, and the enhanced in the arm with enhanced dermatologic management, the rate was 38.6, with a twofold reduction in grade 2 or more. And this is a very significant improvement considering the opportunity to use in the clinical setting amivanta with a dedicated support for dermatological enhancement over the subcute, as you discussed. That is another strategy to increase the compliance of patient, of course, to reduce more the toxicity. And I think that in this view, of course, it's very, very useful also to jump inside of the data more than we discuss now, and also to improve our understanding of the benefit of the two different combos in some subgroups of patients. In particular, the question that I have for you, Enriqueta, that is very crucial for patients with EGFR-mutated disease is what can we do in case of patient with CNS metastasis at the time of diagnosis?
No, I think this is a very important question. So the patients now live longer, and it's important also to treat those patients with CNS metastasis, and also to delay the appearance of a CNS metastasis. So we have some data with the combination. In the FLAURA2, there was analysis in those patients with CNS metastasis at baseline. We have to mention that approximately 35 to 40% of the patients had a CNS metastasis at baseline. And for those patients, the full analysis said what we have seen is that the efficacy was higher for those patients treated with chemotherapy plus osimertinib. There is also data of the intracranial progression-free survival in Mariposa. And again, the combination of AMI plus laser is better when compared to osimertinib alone. And in the Mariposa, amivantamab plus lasertinib was associated with an improvement in intracranial progression-free survival and also intracranial duration of response compared to osimertinib. So I think these combinations are active in patients with a CNS metastasis, but it's true that we need to be prepared also for the second line of patients with EGFR mutations. And perhaps the next question for you, Antonio, is what are the available therapies in second line treatment for patients with EGFR mutations?
So we know that the management of patient with non-small cell lung cancer harboring EGFR mutation progressing to osimertinib is one of the major treaty point in for thoracic oncology. Focus on those the data that are reported by the, for example, the ESMO guideline. We know that is a support and suggested for all patient progressing to osimertinib to try to have a tissue biopsy, or if tissue is not available, it could be better to have a liquid biopsy to try to identify some resistant mechanism in this particular setting. Today, we have no approved treatment according to the different kind of resistant mechanism, but this kind of patient could be prioritized in the clinical trials. For all patients that are not opportunity jump in the clinical trial or without any kind of resistant mechanism, I think that the major data here in the last 24 months were related to the new standard of care worldwide, that is the combination of chemotherapy plus amivantamab that was developed and confirmed in the Mariposa 2 study that was already presented and published, and there now is quite overall approved worldwide. And in this view, I ask to you, Enriqueta, what data supports the combination of AMI plus chemo in the second line setting for patient progressing to osimertinib?
Yes, thank you, Antonio. So, yeah, you mentioned Mariposa 2 trial is a very important one. A patient treated with first line, third generation EGFR TKI at disease progression were randomized to receive what is the standard of care, no? That is platinum pemetrexed, and was compared to platinum pemetrexed plus AMI plus, and also there is another arm of platinum pemetrexed plus AMI plus lasertinib. Progression-free survival was longer with chemo plus AMI versus chemotherapy, the standard of care in all the patients, irrespective of molecular alterations. But also important that the second interim analysis of overall survival in this trial show a trend towards an improvement in overall survival for those patients treated with chemo plus amivantamab second line when compared to chemotherapy, with a hazard ratio of 0.73. But again, it's important to discuss safety, no, in this scenario, no, and also you have a lot of experience in this study and in the combination. And I would like to ask you about the safety of AMI plus chemotherapy in the second line setting.
Yes, the combination of chemo plus AMI did not show any significant important findings. Consider our experience here with amivantamab monotherapy of chemo plus amivantamab also in the Papillon study. So we identified that there was an increase in toxicity, in particular hematologic toxicity related to the standard chemo, neutropenia, thrombocytopenia, and anemia. And generally, we identify more or less the same rate of toxicity related to amivantamab with a very low rate of grade 3 or more that we identify in the chrysalis. For example, we have only 2% of grade 3 of paronychia. We have more or less 6% of grade 3 rash that are globally consistent with all the development of amivantamab, and did not generated an increase in discontinuation with amivantamab. And this was confirmed in particularly considering the benefit in the second interim OS that you discussed before. And also in the data of Mariposa 2, we identified that more or less the rate of infusion reaction at that time was the same that we identify also with in the other trials with amivanta. So globally, a combination that could be considered today, consider safety and efficacy, the real new standard of care worldwide for patients progressing to osimertinib monotherapy. So what can do to manage this safety of the combination of amivantamab and chemotherapy, but also the view of amivantamab, so an improved view for amivanta toxicity across the lines, Enriqueta.
Also, there is another important study that it was presented that is the skipper that analyze different prophylaxis schedules in patients treated with AMI. And I have to say that the conclusion is that when we use prophylactic dexamethasone 8 milligrams BIV 2 days before, and also 1 day before and 1 hour before, and was compared to the prior premedication. With this schedule, there was a clear improvement in the infusion related reaction. So, for those patients treated with this schedule of 8 milligrams of dexamethasone, they BID, day 2, day 1, and 1 hour before the administration, the infusion related reaction was seen in only 22% of the cases, compared to 65% of the patients with standard IRR management. So clearly improve the safety of our patients. So, Antonio, we have other options, no? Now, what are other options are upcoming in the second line scenario for patients with EGFR mutations?
So the scenario of patient progressing to osimertinib, particularly because the first generation and second generation TKI are not standard worldwide, is very exciting at the present time. In particular, in the view of biomarker agnostic. So, as we confirm with the Mariposa 2, it's very difficult to target a single alteration of a resistant mechanism over progression to osimertinib. At the present time, we have many options ongoing in a phase 3 trial. And no great news from the fourth generation TKI, but for example, we are waiting the full results and data from the combination of ivonescimab plus chemotherapy. That data were already reported before in the Asian court of the trial. Then we have a phase 3 in the evaluation for patient with a MET positive resistant after osimertinib. In this particular setting, the phase 3 is the Saffron trial. But we have a lot of data, very exciting data, and in view for the use of ADC. ADC always targeting the biomarker agnostic population. And here we know that we have data from Dato deruxtecan that we'll discuss, Teliso-V, but also we have a very interesting data from patritumab deruxtecan. Patritumab deruxtecan was the first ADC with a defined phase 3 trial fully released this year in patient progressing to osimertinib. And my question for you is, Enriqueta, what data support patritumab deruxtecan in second line, and if these data are supporting this kind of indication?
Yeah. So yeah, an important presentation by Tony Mock during the ASCO meeting, the Artena Lung 02. We wait for the results of this trial, and it is a trial in second line. Patients treated with previously treated with third generation EGFR TKI were randomized to receive patritumab deruxtecan, an anti-HER3 ADC versus platinum-based chemotherapy. And although the progression-free survival was slightly longer, but is not statistically significant, you can see that the PFS associated to patritumab deruxtecan was 5.8 months versus 5.4 months with chemotherapy with platinum pemetrexed. So there was also no differences in overall survival. Toxicity, we know that the toxicity with ADCs has also some relevance, and it's important. There were observed hematological toxicities occur early, probably cycle 1 or 2. But overall, I think this is not a treatment that we need to consider in patients in second line due to the PFS and overall survival results. It's important, perhaps, that we will know better about biomarker, no, in this scenario. So ADCs, should we treat the patients according to a biomarker or not in the Lung02? All patients were included, irrespective of HER3 expression. So, and also it seems that this agent will not be further developed in this scenario. Antonio, the most frequent mechanism of acquired resistance in patients with EGFR mutations is MET amplification. So, should we test the patients for MET amplification? And what should we do in case of MET amplification following a progression?
Yeah, MET is a very important biomarker and target, therapeutic target for patient progression to osimertinib. We know today that there is no consensus in the best testing methods to identify MET in this particular patient population progression to osimertinib. We have data with immunochemistry, with FISH to evaluate amplification, also with the NGS analysis. And now it's not so easy to identify. So we have of course, important data from trials. One of these is the SACHI trials with the combination of savolitinib plus osimertinib versus chemotherapy that could confirm an improvement in progression-free survival analysis for patient with MET positivity after osimertinib, after first and second generation TKI, using this combination. I think that this target would be an important therapeutic target. And at the present time, we have also ongoing the Saffron trial with the same combination. So savolitinib plus osimertinib versus platinum-based chemotherapy for those patients progressing to osimertinib. The major key point, the limitation of this trial is this is the evolution of the Savannah trial second line. The Savannah trial, we know that it was a positive trial for patients with a very high MET amplification, and the rate of this kind of patient is very, very limited. So we are not discussing on 15% of patients, but we are discussing a really low number of patients. So my question is, what data support other ADC here over patritumab deruxtecan?
Yeah. So yeah, we have important data with that potamab deruxtecan, a TROP2 ADC. There was a pool analysis of the TROPION-Lung05 that included patients with actionable genomic alterations, previously treated with targeted therapies, and TROPION-Lung01, that is the randomized trial in second line, only including patients with EGFR mutation. So overall, we have a group of patients with EGFR mutations previously treated with EGFR TKIs and treated with datopotamab deruxtecan. And there was a very interesting response rate of 43%. And we have learned also that we need to manage toxicity of these agents, treatment-related adverse events leading to dose delay was seen 23% of the patients, to dose reductions 22% of the cases. That was also another TROP2 ADC, SAC-TMT, and this is a randomized trial, a small one, in patients previously treated with third-generation EGFR TKI and then platinum-based chemotherapy, and randomized to receive what could be considered the standard of care in this scenario. It was docetaxel. versus SAT-TMT, this new anti-TROP2 ADC. And importantly, the response rate was clearly higher with this ADC, 45% versus 15% response rate with docetaxel. When we analyze the toxicity, we know that we need to manage anemia and also a neutrophil decrease and stomatitis. So I think there are a lot of new potential treatment strategies in this scenario in second line, and ADCs will continue to be analyzed, and we will continue to have results in patients with EGFR mutations previously treated in first line.
Oh, thank you very much, Enriqueta. So this was a very interesting and exciting discussion with this new format, the quick fire format, and we reviewed a lot of data. So that confirmed at the present time that the evolution of potential therapeutic strategy also confirm a therapeutic strategy for patients with EGFR-mutant non-small cell lung cancer is a very important historical time. So we confirm that today we have two new standard for the first line setting using combination increasing progression-free survival and overall survival. And we confirm that one is a chemo-based FLAURA2 and the other chemo-free Mariposa with already OS presented. And also we confirm that for patient progressing to osimertinib, there are many kind of clinical and therapeutic opportunity. The first, the most structured and confirmed is the combination of Mariposa 2 with the chemotherapy plus amivantamab at the present time, the standard of care worldwide according to the different kind timeline of approval. And then we have a lot of data, very interesting, ranging from ADC, TKI in combination that will be out in the next 2 years with the phase 3 data. And this, of course, is a very important perspective and, of course, an important hope for all of our patients. So I would like to thank you, Enriqueta, for this format to join me this discussion. I don't know if you want to thank you all of our attendees.
I would like to thank you, Antonio, and also thank you all for being with us today and to have the opportunity, to discuss this very important topic with so many changes in recent years, and probably we'll see more changes in the next month. So yes, a pleasure. Thank you.
And I would like to thank all the audience. So thank you for all of you that participate in this activity. Please continue to answer the question that follow and complete the evaluation form. Thank you.